All right, good morning, everyone. We're going to get started here. We're a little bit 5 to 6 minutes. Thank you, everyone, for coming to come listen to me talk about Grand Rounds. Today's breakfast Grand Rounds conference is sponsored by Bristol Myers. And today's a big day for us because we're going to be talking about cardiogenic shock and how we really should be thinking about shock, how we as a system and are going to prepare and improve care for our patients. These are my financial disclosures. We're going to talk about the background. I'm going to introduce a case real fast, talk about the history, some challenges in shock, how societies such as SCAI are kind of help organizing a common language, how we talk about shock. So, all right, hopefully everyone's mics and audio is situated here. This is the typical workday coverage for us at Heart Hospital. Normally, in terms of care for patients with cardiogenic shock, these are typical hours that we put in. But in clinical medicine, we have all encountered situations where things don't go optimally. And this is a prime example. I think few of my partners here, including ICU, kind of remember this case. So this is a 56-year-old man with cirrhosis, severe aortic with cirrhosis, severe AS, mean gradient of 40, new cardiomyopathy, who presented with respiratory failure. His blood pressure was running in the 120s. He goes into respiratory failure. They started him on BiPAP at night to help him sleep. Noted to have elevated troponins, worsening renal failure, and we were consulted in the morning. Say, hey, Ray, can you come look at this guy? He doesn't look too good. Then seeing him, he was very minimally responsive, lethargic, and he had to be emergently intubated by our ICU team. And a plan at that time was to take him for emergent left and right heart catheterization. So normally when you see a first shot like this, it's not very, the prognosis is very bad, especially when we're trying to do procedures. His entire left iliac system was 100% occluded. We immediately decided, after placing the swan, we elected to proceed and place a tandem heart device. A tandem heart device is one of these new technologies we are using at the Heart Hospital of New Mexico. Traditionally, in the majority of our patients, I would say 95% of our patients, they would receive an Impella CP device, but due to the severe aortic stenosis, we elected to use this device instead. This is a cannula which requires a transeptal puncture and removes blood from the left atrium, which is oxygenated blood, and the insert cannula is in the aorta. So in addition to severe peripheral arterial disease, he also had severe coronary disease. His right coronary artery was 100% occluded. His LAD was also 100% occluded at that time as well, too. So he's basically living on collaterals from a left circumflex and diagonal system. We did intervene at that time. And he has kind of like, we reopened his C2 of his LAD and provide perfusion back into his inferior wall. A few weeks later, he had stabilized significantly, and he had a TAVR performed with the tandem heart still in. His ejection fraction improved from 20 to 45%. He did have a prolonged hospital course, and he died of unfortunately, of a mucus plug. And he was extubated and talking and almost ready to go to physical therapy. So let's talk about the background. So, cardiogenic shock has been increasing in incidence over the past few years, both in acute MI, but mostly driven by patients with congestive heart failure. And this also corresponds and correlates to increasing heart failure in the United States. But despite the increasing incidence and advances in technology, mortality for cardiogenic shock remains relatively stagnant, approximately 50 to 55%. Also of note is that the use of mechanical support, even though we have a lot newer devices, adoption for mechanical support and use in cardiogenic shock has not increased significantly up until 2017. So there are a lot of gaps in care for cardiogenic shock. This is data or a white paper written by a think tank of regulators, physicians, and other investors in technology. And these are the main gaps that we see in current practice today. When it comes to patients with acute MI and cardiogenic shock, there is no ideal revascularization strategy. We did have the culprit trial, which suggested that culprit vessel only fix for patients with cardiogenic shock. However, there's no there's questions about when you should revascularize non-culprit vessels. We know that patients who do not get revascularized after their initial cardiac event from shock return to hospital more with heart failure. In addition, devices such as use of hemodynamics to this day, including the use of Swan-Ganz catheters, there's been no randomized trial suggesting that it is helpful in cardiogenic shock. Use of mechanical support, hypothermia, we're still going in multiple different directions. And most notably, there is definitely no pharmacologic therapy, including the use of inotropes or vasopressors, that have shown any difference in cardiogenic shock. And what's really interesting, what I'm really going to talk about here today, is systems of care and use of what we call a shock team, which we are launching today. So the problem lies with the definition of cardiogenic shock and its interpretation. Well, if we just go traditionally, what is the definition of cardiogenic shock? It's a low cardiac output state resulting in life-threatening end organ hypoperfusion, hypoxia. But what does this mean clinically? Because as we know, shock is a spectrum of disease. It doesn't just show up, hey, you're in cardiogenic shock. There's often events that lead up to cardiogenic shock. So this is the common language that majority of research studies and we as practitioners should start familiarizing with. This is the SCAI shock, stages of shock. It goes from the most patients who are at risk to the patients who are on death's door. So stage A is those at risk, those coming in and out hospital with heart failure, those coming in the hospital with non-ST elevation MI. We call those at risk, but I think in clinical practice and utility, majority of our patients at our hospital are always at risk. And then the next stage is is the beginning, those that have showing evidence of some hypotension or tachycardia without hypoperfusion. And what I mean without hypoperfusion is some evidence of end organ damage. And then the typical shock patient, what we call classic hypoperfusion, normally requiring some therapies such as pressors, inotropes, or mechanical support. Those that are deteriorating, SCAI would like to consider these types of patients who are in the classic and then that are decompensating rapidly. And then E is extremis, those with ongoing cardiac arrest and with CPR. This form of classifying shock has been validated in multiple registries in Mayo, Hamburg, and Cardiogenic Shock Working Group. That's why it has prognostic value. That's why it is a lot more simplified, although there are a lot of limitations with this type of shock system. But I think it's a time where everyone could kind of say, hey, let's sit down and now we could talk about how patients are in a uniform language and universal diction. In addition, SCAI shock has also identified another modality. In addition to adding the SCAI stages, there's risk modifiers like those with cardiac arrest and coma, those with SIRS, frailty. But what's also interesting that I learned recently is there's definitely different phenotypes of shock. Is an acute shock, such as those with patients with acute myocardial infarction, or is it those patients who live, our heart failure patients who live with an index chronically of 1.8 and they're just slightly tipped their Starling curve? And this is very important to understand is because these types of patients also have different outcomes and trajectories when they present with cardiogenic shock. And in addition, as I mentioned earlier, some of the limitations of shock do not take into account different other phenotypes, such as when you have additional organ failure and renal or liver injury. If we look at patients with just what we call phenotype 1, this is work done by and proposed by Naveen Kapoor with a cardiogenic shock work group. So if patients with phenotype 1 normally have some type of left or right ventricular dysfunction. If they present with SCAI stage C shock, which is the classic shock, their in-hospital mortality is only 7.9%. But if you add renal failure and you present in, so that would be combined phenotype 2, would be 1 and 2, mortality increases substantially. And when you have all three phenotypes, mortality increases proportionally as well. It's 61% if you have SCAI phenotype 3 and reaching stage D shock, meaning you're deteriorating. So as I mentioned earlier, patients with acute MI versus heart failure, these are very different folks. And there were times before where me and my partner, Mark Beanyars, were going in to the cath lab, taking a patient who was decompensated, but this is a chronic CHF patient. Their normal presentation when they present with cardiogenic shock, it normally is a congestion model where they have initiation of congestion, retention of fluid, which ultimately leads to hypoperfusion and hypotension. Then the other side of the equation is patients with acute MI. They lack these compensation models. How analogous to these type of patients are patients with tamponade. There are those patients with cancer or other or needing dialysis, and their pericardium is able to accommodate large volumes. Whereas if I had a coronary perforation in the cath lab, as much as 50 cc's of blood can lead to very fast decompensation and death just with a minimum amount of blood, because there lacks a compensation biochemical remodeling of the heart, which doesn't allow for that. This is from the cardiogenic shock work group, and they have demonstrated the mortality in patients with acute MI and heart failure cardiogenic shock. What's surprising is that majority of patients in their registry were almost 2 times as many patients with heart failure cardiogenic shock than acute MI, and this is over multiple institutions. However, if you look at the mortality for cardiogenic shock acute MI, it's almost 2 times more than heart failure cardiogenic shock. At the bottom shows the use of device therapies and mechanical support for heart failure cardiogenic shock. Look at 42% of patients with heart failure cardiogenic shock did not receive any devices. And like I said, there are a lot of our patients out there who live with a cardiac index of 1.8. Maybe it's how we define these patients and cardiogenic shock, because their mortality, despite their mortality being lower and their use of mechanical support devices being lower, there's definitely a difference. This is another slide showing that even at the baseline stages D and E of SCAI shock, acute MI have worse prognosis than those with acute decompensated heart failure. These are pressure volume loops, as I've described in the past, where chronic heart failure cardiogenic shock, they're able to accommodate larger volumes of decompensation, and pushes the starting curve to the right, where patients with acute cardiogenic shock from MI, they're unable to tolerate these changes due to lack of biochemical neurohormonal compensation. When studying or reviewing for these grand rounds and going to recent lectures, there was a question always on my mind, is that a lot of heart failure transplant centers use balloon pumps to manage a lot of patients, probably mostly those without acute MI or coronary disease. And I was always questioning in my mind, why are these practices done? Because I have been always a strong advocate of Impella. And this is why, is that these models that I've demonstrated right now, patients with acute cardiogenic shock due to MI and versus patients with acute decompensated heart failure, they're very different patients. One type of patient has a compensation model, and maybe those patients with acute decompensated heart failure, a lot of times we manage them with just inotropes, and there is a potentiation that maybe balloon pumps can provide therapy just to tip them back in the other side of the Starling curve. There have been, as you know, the limitations of the SCAI stages of shock also lack clinical markers to help us understand what stage they are. And this is a proposed model for from the Naveen Kapoor's group, saying that these are the parameters they found that are also prognostic, that are correlate with these stages. Those patients in stage C shock, their lactates will normally be less than 5, and their ALTs and pH are normally within reference range. But those patients who are deteriorating, and this is very important because we want to treat patients in the B or C shock and initiate early therapy. And then we also want to consider escalation of therapy if these things don't change before we reach into stage E shock. So these are, this is not obviously been fully tested in a prospective manner yet, but we are getting some framework of reference to treat our cardiogenic shock patients. What is very important, and I think what everyone should really focus on, is that with the SCAI stages of shock, this has been validated in their multiple registries, is that if you present with a certain, let's say a level C shock, and then you actually change your from C to B, your outcomes are significantly better. Those that have the same classification both in their entire hospitalization, during their index hospitalization, if their SCAI stages remain the same or worse, your mortality is exponentially increased. So treatment of shock. So this has been kind of like the history of shock. Balloon pumps, I did not know, was developed in the 1960s, and it was inserted from a surgical cut down. In the 1970s, PCI was initiated, and there were some placements of balloon pumps, but it went, so mortality for acute cardiogenic shock went from 80 to 60%. But however, the past 20 years, despite PCI, balloon pumps, therapies such as percutaneous LVADs, mortality is still the same. But if we look at the amount of clinical randomized clinical trials helping us guide therapy for cardiogenic shock, if you look at it, there's only been 2,500 patients randomized in the entire world over the past 2 decades. So we're trying to use, and this represents that to perform studies, and especially randomized controlled trials in patients with cardiogenic shock, there's a lot of ethical concerns in terms of enrollment. So other therapies not really supported by any randomized controlled trials are right heart cath or Swan-Ganz catheters. I allude to the ESCAPE trial. The ESCAPE trial was a heart failure trial using swans to manage care. It was a negative trial for management of acutely decompensated heart failure patients, but this trial is often misquoted, saying that there is no benefit in patients with cardiogenic shock. And this trial should not be used in the same context when we talk about cardiogenic shock. We frequently use inotropes, dobutamine and milrinone, to support blood pressure and cardiac output. We use anticoagulants and antiplatelet therapies in cardiogenic shock. Drug-eluting stents have not been tested in cardiogenic shock, and ECMO therapy, there are some randomized control trials currently going on, and that we do not have any randomized controlled data on. So this is data for, although I'm a speaker for Abiomed has been a large contributor to attempting to help treat our patients and kind of like dispel many of the myths and problems that we encounter in cardiogenic shock. But as I mentioned earlier, randomization and enrollment is very difficult. Multiple studies have been discontinued due to low enrollment. There's a lot of consent-related issues in all cardiovascular trials, especially when patients are very ill. 40% of family members available on scene for a patient with cardiac arrest are unable to provide informed consent. 63% of cardiologists reported patients only sometimes, almost never, or never know what they're accepting or refusing. We are part of, a very big trial right now, STEMI DTU. Patients are sometimes in extremis, are unable to provide consent. If you ask them later if they remember what's going on, then they don't really remember. 55% of patients who participated in a STEMI trial don't remember reading about consent or remember what happened. Another 80%, like I said, did not read the information provided to them in a very acute manner because they were having an MI. So is there a pathway to perform randomized control trials in a cardiogenic shock patient? Yes, there are. The FDA, there is a code 21 CFR. There is very difficult, in addition to having patients being unable to be consented, there has to be a public message in the community prior to initiating a trial. They have to have their own independent sponsored IRB, own independent committee. So there is a pathway in the United States for a trial that you do not require informed consent. But if we look at Europe, there's two centers right now in Denmark and Germany, which allows for consent not to be obtained. And this is in a certain clinical situation, the patient is incapable of providing informed consent. Consent can't be obtained from a surrogate, and the research specifically involves a condition with possibly a benefit. And Germany and Denmark have been recruiting for this acute MI cardiogenic shock with percutaneous LVAD support. So there is some data that we may see in the next few years that help guide us to our therapy. So you can't really talk about contemporary management of cardiogenic shock without understanding the work done by Bill O'Neill and his group. He started the National Cardiogenic Shock Initiative, started in Detroit, but it also listed a lot of cardiogenic shock happens not at a hub and spoke center, but it really happens in our community, a community hospital like ourselves. So there's 80 participating hospitals, 400 patients enrolled. It is a prospective, non-randomized, single-arm, multi-center study. Their objective was to assess the impact of early mechanical support guided by invasive hemodynamics in acute MI. They enrolled patients from July 16th to 2020. Exclusion criteria were they can't have a balloon pump prior to impella insertion, unwitnessed cardiac arrest, other mechanical complications of acute MI. Of note, 25% of their patients, this is real world study, were in stage E shock. None of the randomized controlled trials, none of the data, or any prospective trial in cardiogenic shock really were able to enroll these patients. And despite 25 of these patients, they did demonstrate 50% survival in this cohort. So this is their data for cardiogenic shock. So if you take all comers, the median survival was 68 77%, which is unheard of. Traditionally, all shock trials and shock data shows about 50% survival. So this strategy that they implemented really is starting to show survival and cardiogenic shock with early invasive monitoring, with early mechanical support. And what other lessons learned from their study is that increasing use of inotropes and vasopressors portends to worse outcomes and mortality, as we can see here. They were very strong advocates of using PA catheters and swans to help guide therapy, which is part of their management of cardiogenic shock patients, and led to improved outcomes, better LVAD utilization, and better heart transplant utilization. Another key thing or parameters which was identified in their work group was the concept of cardiac power output. Power output was one of the strongest prognosticators correlating with survival. If cardiac power output is a product of your cardiac output multiplied by your mean arterial pressure at that time over 451. There's a calculator online that you could find. And if you had a cardiac power output of greater than 0.6 and minimal evidence of end organ hypoperfusion demonstrated by a low lactate, you had 88% survival. But if you have a cardiac output less than 0.6 and high lactate metabolic derangements, you had very poor survival. But these parameters here are kind of illustrating certain therapy guidelines or thresholds which we should consider about increasing our support use in these patients. These are their etiologies of mortality. So of their patients presenting with cardiogenic shock, 60% of them died from cardiogenic shock, whether it's arrhythmia or other or complete cardiac failure. Of note, only 20% of their patients went on to escalate therapy, because this was an idea or concept early on. There's going to be future trials trying to demonstrate that if you have a patient, if their cardiac output is less than 0.6, would escalating therapy such as increasing their support from Impella CP to Impella 5.5, ECMO, tandem heart may potentially benefit patients. And in the future, we may have even better outcomes than 70-80%. So now I want to talk about the shock team, and this is what we're starting here at Lovelace. So what are the goals of the shock team? It's to facilitate early shock recognition, expedite multidisciplinary discussions regarding evaluation and management, including the need for timely mechanical support and appropriate device selection. Why implement a shock team? Well, as I illustrated earlier throughout my slides, that cardiogenic shock, it's a very complex syndrome with high mortality. Patient management it's very variable depending on who sees that patient. Shock teams, what has been demonstrated is that with protocols, reduce variations in care. And this is a article published in JACC of last year, comparing 24 institutions, 14 of them having cardiogenic shock teams and 10 that do not. What was found is that institutions that have cardiogenic shock teams, there's more use of right heart catheterization and Swan-Ganz catheter placement. Overall mechanical support when you have a shock team is actually less. And this is driven by the fact that majority of institutions who do not have shock teams use a balloon pump for their management. I could tell you that maybe for the heart failure patient that in cardiogenic shock, they may potentially benefit, but for patients with acute MI, we at this institution strongly believe that a first-line therapy should be devices such as our Impella device. And lastly, mortality in patients with cardiogenic shock is definitely less in places that have shock teams. So how are we modeling our cardiogenic shock program and our shock team? And this is we are following the path of Inova. Inova Heart is a community hospital very similar to ours, who started their shock program approximately 6 years ago. And they have demonstrated really interesting results that hopefully we can mimic here. Their catchment area or geographic location is very similar to ours. However, their population density is definitely a lot larger because they have to cover Maryland and from Maryland to Richmond. So they did a root cause analysis of the problems in their care for cardiogenic shock patients. One of the interventionalists there, they were telling me they have 50 interventionalists there at the hospital. Each of them alternates care during multiple times of the month. One operator may do over 100 PCIs a year, and you have another operator doing only maybe 2 PCIs a year. So like I said, so they identified that there's definitely fractured care. There was no formal process for evaluating cardiogenic shock patients. They also found that late detection also worsens outcomes, impaired access to care, delays in transfer, and because there's different operators, there's inconsistent timing and inconsistent types of care provided for patients with cardiogenic shock. And they developed a plan very similar to ourselves about how they're going to change things. And they adopted the strategies used in the National Cardiogenic Shock Initiative, using early Swan-Ganz catheters, developing a shock team. This is the shock team, and comprised of interventional cardiology, advanced heart failure, CT surgery. They developed algorithms. They picked a date to go live. Our go live date is today. And that's where we're at right now. And it took them about 6 months to develop their protocols. And then after every shock patient, they developed their own registry. And like how we do STEMIs, we have after action reviews to improve their processes. They started out with 100 cases a year, but when currently they have approximately 300 cases a year of cardiogenic shock, which includes transfers. And more importantly, they used, surrogate means kind of like ours about their baseline shock mortality, which is 50%. But after implementing their shock program, shock team, and protocols, they increased their survival from 50% to almost close to 80%. And this was also seen in the National Cardiogenic Shock Initiative, 80%. Other institutions are also demonstrating this improved survival. And hopefully, if we're able to change our outcomes from 50% to 80%, we have definitely provided a new way of thinking about shock, and hopefully we will be leaders in management of cardiogenic shock. They have created a hub and spoke model. As I've mentioned earlier, their kind of like referral base went from a very low number. Now they've become a true like heart failure center. And, we are very similar to them, except that we do not provide cardiac transplant here, but we do have a fledgling LVAD program that we do want to grow and provide care, because we are one of the, we're the nation's third poorest state, but yet we do very advanced care here. We provide really coordinated care as well. So this is our cardiogenic shock protocol, which is listed in front of you. Sorry, there's typos here. This is not the final version, but it all starts with activation. So cardiogenic shock team activation, cardiogenic shock is recognized on the floor. And as I talked earlier, this is why we have a cardiogenic shock team. This is the people on our cardiogenic shock team. Cardiogenic shock is going to be activated through our one call system, and call the cardiogenic shock team when you suspect cardiogenic shock. And these are the clinical criteria that we are going to call cardiogenic shock. They have to present with a heart symptoms. So they either are going to present with acute coronary syndromes, they're going to have elevated troponins and chest pain, or they're going to present with heart failure. I think an important part, what I mentioned earlier, patients with acute decompensated heart failure and cardiogenic shock, their volume status is significantly high. That's how majority of cardiogenic shock patients with acute decompensated present. They are not the febrile patient. They are not the patient that is having a GI bleed. So please consider this before activating, and really say that they have a cardiac etiology for the reasons of shock. There's also hemodynamic criteria, especially if we're getting transfers from the outside. I think we are going to request, if they have the capabilities, to insert a SWAN. The Swan-Ganz catheter management will definitely dispel if it's a cardiac etiology or not, or even a mixed picture. Contraindications for cardiogenic shock: if they're DNR, they have a terminal illness, and the other consideration is that they cannot be anticoagulated for some reason. We're going to implement protocols in the EPIC system. Labs should be drawn as standard. So now we've laid out the guidelines for activation. We also have it for coordination. So after one call is activated, we as the cardiogenic shock team are going to have to decide therapy in a multidisciplinary discussion. Me or Dr. Boivin are going to be on the same line during the night or during the day if we're on the cardiogenic shock team consult team, and we're going to have a multidisciplinary shock discussion. Not every person, as Mel Prata says, needs a dive with an Impellus. There's certain therapies, due to the lack of resources and how we provide care, it should be definitely in a coordinated, consistent manner. Not, hey, you have a different provider, they think they should get this. And this is what multidisciplinary discussions facilitate. So after coordination and activation of the shock team, it's about, this is basic guidelines for management in the ICU. Especially, we need to serially assess these patients and identify those with refractory shock. I think the first 4 hours of our time after any mechanical support, after the patient arrives to the ICU with mechanical support or not inotropes, there has to be frequent reevaluation, especially identifying those with severe refractory shock. And if they have a severe refractory shock, we as the shock team have to come together and really identify what kind of resources should be disposed of. Should we escalate therapy using ECMO and Impella CP55? So these are protocols that are written. This is not the final copy because I understand there are still some typos in this, but this is the same protocols that Nova Heart is using right now. These are the same game plan that we are not reinventing the wheel. We are trying to achieve very similar results to other institutions that have shock teams, and they have demonstrated improved outcomes. So summary, cardiogenic shock, it's a very complex syndrome. I think the SCAI stages of shock is providing some common ground and classification that we all should be familiar with. We are not going to get many randomized controlled trials at this time due to the ethics of informed consent. I think cardiogenic shock teams definitely improve survival, definitely improve care, and that's why we're going to take on this task in this region. We're going to be the only cardiogenic shock program in this entire region at this time. I want to give special thanks to Maria Tencio and Jill Harrington Abiomed. These two people have been instrumental in helping us develop our cardiogenic shock program. Thank you.
For their cardiogenic shock, they need to be trained because they're going downhill. So that, I mean, that's going to be the next step in this, is really talking to people. And so as we talk to people that are sending in patients, you know, Las Cruces sent in a 32-year-old who a lot of you have rounded on, and he had a lactate of 11 and transaminases of 3,000, INR of 6.3. I mean, just total organ dysfunction, and she's still going, and we've just kind of applied the protocols. But we have to get that word out to the referring that, you know, she shouldn't have been referred here a week into her shock. And we got another patient with pH of 6.7 from Loveless downtown after for 3 days. That should never happen. So I just want to challenge everyone that's interacting with referring providers to just, you know, be continually educating, and then we're going to be going out into the periphery and also doing education.
So I want to highlight some of Mark Vigner's concerns is that we have a plan developed, and with marketing and strategy for Loveless, we are doing a soft launch only here, just in these two institutions, and figure out all the needs that will be required that to take other patients. Do we have the hospital capacity? Do we have the nursing staff to take care of these cardiogenic shock cardiogenic shock patients? I think the discussion comes to first evaluation is activation. Then we're going to have, there are other
key players in our cardiogenic shock team, and that's the ICU mid-levels, who are definitely the frontline people who are evaluating cardiogenic shock patients. Another key component, like as I mentioned earlier, is multidisciplinary discussion. It's not going to be the interventionalist or general or the captain on the floor making decisions on how we manage patients with cardiogenic shock. It's going to be cardiogenic shock patients are going to be treated in a consistent, protocolized fashion, so there are no variations in care. We are going to be growing our shock program. As I mentioned earlier, their shock program went from 100 patients to over 300 patients a year now from referring facilities. We are going to provide our protocols for institutions, because I truly believe that this is going to be standard of care in the next 5 to 10 years. Institutions having cardiogenic shock teams that can have cardiogenic shock teams. And for other, I think every service line that we have, from vascular surgery to CT surgery, cardiogenic shock is going to be useful, because I already talked to Trent. He wants to start a PE program, and these patients are a form of cardiogenic shock. From our program, we're going to grow into a larger LVAD program, because these patients need exit strategies such as LVAD. Unfortunately, I don't think we have the numbers at this time to create a heart transplant program, which we did have in the past, but maybe more Californians will come here and we'll grow our population. So there's a lot of change. Please be patient with how we try to coordinate and structure our process. Things are always changing in shock. These numbers here may change tomorrow, as long as when we get more data.
No, there's no way.
Other questions? Yes, Trent.
So in the vascular world, we have a hard time, not only with our mid-level providers out in the periphery that are very isolated, with sort of the influx of locums. I'm not invested in the community docs out there. We have helicopters and airplanes bringing in people with dry gangrene in their toe that's been there for 3 years. And then they sit around and the length of stay is kind of higher for multiple reasons. But do you feel as though the weeding out process will be reasonable enough so that we don't have this massive influx of shock patients with, by the way, sepsis and stuff, that are going to be brought into the institution and clog up our system? Because there's nothing, as we've seen, there's nothing that can system like lack of perfusionists, et cetera, et cetera. So how do you feel like that's going to be?
So, like I said, number one, we're going to have a multidisciplinary discussion. I am not an expert at gangrene. I am not an expert at sepsis, but I do know people who are, like you, Dr. Boivon here, and we control the floodgates of who gets transferred in and transferred out. Other institutions, I think we're also having a campaign where Dr. Boivon is going to teach bedside echo to especially our ER docs here. They have echo capabilities, and eventually when technology and costs are already decreasing for handheld echo devices, you could find one about $8,000. That would be very instrumental. If you just put a probe down, you'd know if it was cardiogenic or not. So there are measures, and like I said, things are changing. We still control the floodgates. I'll give you an example. University of Utah, they have tons of people wanting to transfer patients for heart failure transplant, but yet there's a discussion between referring providers and them, and they control their floodgates about who comes into the hospital and who doesn't. But I think the burden should not be relied on one doctor, one person accepting that patient. As we as an institution say, hey, we're going to take this patient and we're going to commit everything to them, but we have to fully be able to demonstrate that we are able to take care of these patients with 100%, not half, for care. All right, I just want to thank you, Bristol Myers, again for sponsoring Grand Rounds. Thank you for everyone for participating, and there will be more to come. Thank you.